going back to the presentation, let's talk about how thalassemia actually affects the body. In this case, we'll talk about beta thalassemia, but it's going to be the same for alpha thalassemia as well. You just replace the globin chain. So hemoglobin normally has 4 chains, 2 alpha and 2 beta. That leads to normal erythroblast production and normal red blood cells. But if you have a reduction in beta globin synthesis, it can lead to beta thalassemia and abnormal erythroblast production. So a majority of these erythroblasts are going to die in the bone marrow, leading to ineffective erythropoiesis or premature death of these red blood cells. But a few of them are able to leave, and they will become hyperchromic red blood cells, meaning that they're paler than normal due to that deficit of hemoglobin. These hyperchromic red blood cells will lead to destruction of red blood cells in the spleen and ultimately anemia. So as I mentioned earlier, most of these red blood cells are going to die in the bone marrow. So there's going to be a decrease in your iron. To compensate for that, the body is going to increase its iron absorption that comes from dietary intake. And that can lead to adverse effects on the heart and liver. And the anemia that ultimately results can lead to tissue anoxia, which is the lack of oxygen going to the tissues, and erythropoietin increase, leading to bone marrow expansion and skeletal deformities. So to help combat these symptoms, blood transfusions are key. However, these blood transfusions have some adverse effects as well. It can lead to systemic iron overload. And we'll talk about how to combat that a little bit later on in the presentation.
So for signs and symptoms, so some babies will show signs and symptoms right at birth, others will develop signs and symptoms after the first 2 years. People who have heterozygous thalassemia often will not show any symptoms. So the 6 most common signs and symptoms are dark urine, abdominal swelling, fatigue, yellow discoloration, facial bone deformity, and weakness. So complications that can arise with thalassemia can either be moderate or severe. So for moderate, you can have iron overload. So this is when there's too much iron due to the disease or from blood transfusions. You can also have an increased infection rate. So then the severe thalassemia include bone deformities. So thin and brittle bones can form, and enlarged spleen due to anemia, and then slow growth rates. So like delay in puberty and your growth, and then heart problems could also occur. So congestive heart failure is one of them, and tachycardia. So then I will move into how to diagnose thalassemia. So we need a complete blood count. So this will measure the amount of hemoglobin and different types of blood cells in your body. So people who have thalassemia will have fewer and less red blood cells than normal. So a special hemoglobin test will measure the types of blood, and then you can also do genetic testing, which will help determine the specific type of thalassemia you may have.
All right, so now let's talk about our treatment options. So the treatment options for thalassemia depends on the type that you have and how severe it is. So one of the main treatment options for moderate to severe thalassemia is a blood transfusion. So with blood transfusions, you're receiving healthy red blood cells that have healthy and normal hemoglobin. And then another option is chelation therapy, and this goes back to overcoming the systemic iron overload. So chelation therapy is done when there's an increase in iron deposit in various organs of the body. And iron chelators are going to be given to the patient to help remove that excess iron. You also have blood and bone marrow transplants. You could also call them stem cell transplants. These are the only known cure for thalassemia at this moment, but it's not done often because it is hard to find a good donor match for these patients. And then finally, you have some gene therapeutic options. So gene therapies are the latest advancement in the treatment for severe thalassemia, and it involves the use of the patient's hematopoietic stem cells. We'll talk about that in a little bit more detail when we get into the next slide with our recent findings. So as of August 2022, the FDA approved a drug called Zynteglo, which is the first cell-based gene therapy for treating adults and pediatric patients who have beta thalassemia and receive frequent blood transfusions. And the reason why the development and approval of this drug was so novel is because it's administered as a single dose. It's personalized treatment that involves genetically modifying the patient's hematopoietic stem cells and having them make normal beta globin components. The patients will then undergo a procedure that's going to destroy the present beta globin cells or hemoglobin stem cells. And the patients will then be transfused with these genetically modified ones. And the goal of it is to induce normal erythropoiesis and allow for normal production of red blood cells that have healthy hemoglobin and help reduce these symptoms of anemia.
There are references.
Bernard and I will be presenting hemophilia, the royal disease. First and foremost. Sorry. Hemophilia is a rare bleeding disorder. It is the most common form of blotting condition, specifically type A. It is also the first human genetic trait found to follow a sex-linked inheritance pattern. There are 3 forms, form A, B, and C, and bleeding can occur anywhere in the body, but mostly occurs into joints. So as you can see in the picture, both have normal blood vessels, but when it's damaged, hemophilia patients have the inability to clot their blood. So the genetics, types A and B are both sex-linked recessive. Type A affects clotting factor number 8, and type B affects clotting factor number 9. And both of these are located on the X chromosome, so they mostly affects males. Type C is autosomal recessive, and it affects coding factor number 11. But these can also occur spontaneously. So if you look at the pedigree here, this shows the pattern of inheritance. There is a carrier mother, and they have a 50% chance of passing the disease to their son, and they have a 50% chance of passing the gene on to their daughter as a carrier. But when the father has hemophilia and the mother does not, all of their sons will not have hemophilia, but their daughters will all become carriers of the disease. So the mutation has to do with transposable elements, otherwise known as jumping genes. These elements move from one gene to another because of close proximity, like shown in the picture down here. The specific one that the mutation is due to is lines. So long interspersed nuclear elements that encode enzymes in the transposition. So there are several other diseases that have to do with transposon-generated mutations, such as acute intermediate porphyria, Duchenne's muscular dystrophy, familial adenomatosis polyposis, hemophilia A and B, and then X-linked severe combined immunodeficiency. So let's throw it back to biblical times. In AD 30 through 36, the first record of a bleeding disorder had to do with the report of the bleeding woman, the hemorrhaging woman in the New Testament Bible. That wasn't specifically hemophilia that we know of, but it is the first of the bleeding disorders. Fast forward to AD 600, when the Jewish Talmud law had all the baby boys circumcised ceremonially, but if they had hemophilia in the family, those babies were excused from this ceremonial circumcision. In the 10th century, there was an Arabic physician who described many of his families, or families that he saw, their male relatives were dying of uncontrollable bleeding disorders. Then in the 1800s and 1900s, Queen Victoria's descendants suffered from this disease as well, but that diseased lineage was ended when there was an overthrow of the Romanovs. Later on, when we knew about DNA, they found the graves of those who were assassinated and tested their DNA. And instead of hemophilia A, which they previously thought, it was actually hemophilia B that her descendants had. So here is the pedigree. As you can see, anyone past here is not affected and is not carriers anymore. And here is the assassinated Russian royal family, which was the last. So now I'll pass it on to Berdith, who will go over the different types. Oh, sorry. Demographics. Hemophilia A is 1 in 5,000 males. About 400 male babies are born with this disease each year. Anywhere from the time between 2012 and 2018, roughly 300,000 males were living with this condition, and of those, 1/3 of the babies were born with no family history of the disease. Worldwide in 2021, it was collected that 233,577 hemophilia cases were reported, and of those, 81% were male. Now I'll pass it on to Bernard.
So hemophilia A versus hemophilia B. A is known as the classic hemophilia, which is a lack of or decreasing factor 8. And hemophilia B is known as Christmas disease. It has no relation to the actual holiday Christmas. It's just named after a baby boy named Stephen Christmas. And it is caused by the lack of or decreasing factor 9. So right here is a picture that depicts hemophilia A versus hemophilia B. You could see that hemophilia A occurs more frequently than hemophilia B. They're both X-linked, as we talked about, and they both share the same clinical signs and symptoms, which I'll discuss later on. And then for the characteristics of the missing clotting factor, with hemophilia A, its function is the cofactor, whereas with hemophilia B, its the function is the enzyme. And then here is a pie chart that depicts the gene deficits reported in both hemophilia A and versus B. So with the signs and symptoms, bleeding occurs in the joints, skin, mouth, or gums, and in the head. And patients are known to also have bleeding after getting vaccinated, uncontrolled bleeding that won't stop, and bleeding can be found in the urine or stool. And females are reported to have heavier than normal menstrual cycles, and frequent nosebleeds may occur. So how do we diagnose it? So generally, if you are a known carrier, you might opt to get genetic testing. And if you are pregnant, you might decide to do genetic testing of the fetus, but with that comes some possible side effects of losing the fetus. In severe cases of hemophilia, usually patients are diagnosed within the first year of life, and milder forms may not be apparent until adulthood. And some people may learn that they have hemophilia through excessive bleeding during surgical procedures. So this might happen during a baby boy getting circumcised, or this might happen during delivery, during a C-section when the baby's coming out and the baby may have blood stuck in their head. So then the doctor might decide to do some diagnostic testing, and the test might include CBC, activated partial thromboplastin time test, prothrombin time test, fibrogen test, and a clotting factor test. With the clotting factor test, it tests the severity and the levels of the factors 8 and 9 in the blood. So a normal person would have 50 to 100%, where a person with mild hemophilia may have greater than 5%, but less than 40%. And a moderate hemophilia may have 1 to 5%. And severe hemophilia may have less than 1%. So the treatment options. So to treat hemophilia, you must replace the missing blood clotting factors so the blood can clot properly. This can be done by injecting treatment products called clotting factors in the person's vein. And there are 2 types. It is called plasma-derived factor concentrate. So plasma is collected from different people, and then it goes through several processes and separated into clotting factors. Then the clotting proteins are then made into freeze-dried products. Lastly, it is tested and treated to kill any potential viruses before it's packaged for use. And with recombinant factor concentrate, since 1992, it has been genetically engineered using DNA technology. And so it is commercially prepared factor concentrates are treated to remove or inactivate blood-borne viruses. So we have desmopressin. This is the hormone that can stimulate the body to release more clotting factor. And imizikibok, this is a drug that prevents bleeding episodes, specifically in hemophilia A. And what it is a mononucleic antibody that restores the function of the missing activated factor 8 by bridging factor 9A and factor 10, mimicking the activated factor 8 independently of factor 8 levels. So we also have clotting preserving medications, fibrin sealants, gene therapy, physical therapy, and first aid. And so as of recent findings, the FDA recently approved back in November 2020, a $3.5 million gene therapy for adults with hemophilia B. So what it does is it uses HemiGene-X, which is a one-time gene therapy product given as a single dose of IV fusion. It was developed by Dutch biotechnology company called UniCure. and it now is currently manufactured by CSL Bearing LLC. And so in conclusion, the goal is to give patients a better quality of life by finding ways to prevent and treating bleeding episodes. And there are sources.
Thank you. Any questions?